Hello, everyone. Welcome to this roundtable discussion, navigating new frontiers in healthcare, building a care team that really works. I have been looking forward to this conversation and frankly, a fun excuse to get some friends, new and old, together to really talk about something that is near and dear to each and every one of our hearts. I'm joined today by Dr. Bonnie Feldman of Bonnie 360, and Dr. Zach Spiritos, a GI specialist, and Dr. Brittany Panico, who is a rheumatologist. And really, in this conversation, we are hoping not only to bring together these innovative, really healthcare pioneers, but to talk about and explore the urgent need for getting creative when we think about how we are bringing our expertise and really partnering with our patients who have complex chronic illnesses like Sjogren's and other related conditions, and thinking about how we can reinvent the wheel in a better, more effective way to help one another. So I'm going to start by letting Dr. Bonnie introduce herself a little bit. We'll kind of get to know everyone, and then we're going to dive in.
Thank you, Kara. I'm so excited to share what I would consider a pretty global perspective on the problem. I started as a practicing clinical dentist, transitioned to Wall Street, where I worked as a buy-side and sell-side equity analyst in healthcare. And then I became an autoimmune patient advocate for myself, my family, and my now 10 grandchildren. Along the way, I got to use all the skills I acquired, and I became an analyst for venture capital funds until finally I started a virtual integrative rheumatology clinic called Remission. It was a venture capital funded startup. And we learned a lot about what to do and what works. And it had a very interesting care team model. And we also collected data. So we have early data to share in terms of how the patient outcomes were improved while costs were reduced. Sadly, I must say, we recently closed this clinic because we couldn't raise a Series A. But that's a longer discussion on financing models, venture capital startups, and in my world of venture investing and venture capital startups, this is not something to be ashamed of. It's something to be proud of that we started it. And myself am super proud of our accomplishments because it was started when I was 67 years old and mostly as a legacy to my 10 grandchildren.
Amazing. Let's learn a little bit more about Dr. Panico.
So I'm Brittany Panico. I'm a board-certified adult rheumatologist, and I founded Summit Rheumatology, so independent of healthcare system in private practice. And we've developed practices in Arizona, Colorado, Oklahoma. We have office locations in Washington and West Virginia as well. So we are growing, and that's really exciting because I think our model of care really is trying to be different than typical insurance-based practices, meaning that we're devoting more time into partnering with our patients. Really, the whole purpose of creating Summit Rheumatology is because we know autoimmune diseases require a team, the patient, the healthcare team. And so we are there to help you as the patient climb your summit in whatever way that means to live your life to the best of your potential. So I'm really honored to be back for my second year speaking at the Sjogren Summit, and really have just found the niche of treating patients who are considered the underdogs. I love to partner with people who have found their journey in different ways and come together to really collectively partner together rather than the typical, I'm the doctor, you're the patient, this is my advice, and this is what you do. But rather be on this journey alongside with you. And I think Dr. Kara's message of what she's creating really speaks to that partnership. So that's really the gist of what I try to provide as well.
Amazing. And Dr. Spiritos, you have just launched your new practice.
I have. Tough acts to follow. You guys are all amazing. I'm a neurogastroenterologist, so we deal with the tube, but also the electricity that connects the tube to the brain. I recently left a position at UNC to create our new clinic, which is telehealth-based, called Ever Better Medicine. It is a telehealth-based clinic that focuses on complex GI conditions. We also treat mast cell activation syndrome, We treat postural orthostatic tachycardia syndrome, amongst other autonomic issues and conditions. We also recognize and treat complications of folks living with hypermobility, whether it's hypermobility spectrum disorder, hypermobility Ehlers-Danlos, or Ehlers-Danlos syndrome. These are very, very complex conditions that there is no algorithm for. There's no FDA-approved medications for these things. A lot of it is trial and error, unfortunately. But what it does require is tremendous partnership between the patient and the provider, working in lockstep, constant communication. And that's what our clinic aims to provide, is personalized, individualized, patient-centered care in your living room, in your pajamas, with the ability to talk with us 24/7, because unfortunately there's no set and forget it treatment plans for these patients. We start something, sometimes it works, sometimes it doesn't work. And success depends on our ability to communicate and talk and figure out what works for every individual. We also bring together exercise physiologists and registered dietitians who are savvy in dysautonomia, histamine intolerance, irritable bowel syndrome, gastroparesis, and the like, to create holistic plans for these patients. So we give folks time and the attention that they need to get control of this invisible chronic illnesses that are misunderstood, minimized, and really, really challenging to control.
So I know several of us, as we were kind of talking while we were getting our tech figured out and things, have had a shared experience that we have left either academia or, kind of bigger healthcare systems. And I would love to hear, Dr. Zach, you're the one who's left the most recent. What was it that you found challenging or lacking or pushed you to make that change?
The nature of what I saw and wanted to treat in clinic was very tough to do in the traditional model. I think our healthcare was built on the germ theory, where a century ago, the primary cause of illness was infectious disease, where we found a bug. And so if we treat this bug, we'll take care of whatever's going on, right? And then this evolved. And over time, our healthcare system was full of heart attacks and strokes. And we got really good at protocols for these very definitive issues, right? So time to stent, right? Time to TPA, right? And we're really good at treating these issues. But when it comes to chronic, complex conditions, especially ones where we don't really have any diagnostic clues as to why in the world it's happening, there's not one thing to treat. You got to understand the person, how they got there. And so in a world where there's a lot of uncertainty, there's not one diagnostic test that will tell us everything. And furthermore, there's discordancy between people's symptoms and what they care about, right? So you come in for diarrhea, like I can give you Imodium, anybody can do that. Pepto-Bismol works, right? But what happens if it's the anxiety around eating that drives them crazy, right? So how do you work on that? And that's where you talk about sleep and diet and cognitive behavioral therapy and all the other things that you can't address the person with the symptoms in 30 minutes of time. And so I think time was the biggest issue for me that I was always behind. Everybody was mad at me in clinic because I try to give everybody the time that they need to tell their narrative. So I'm never getting a lunch break, right? I'm always running late. Everybody's pissed off at me. And that's not why I left. But I just felt like I wasn't doing patients their due diligence. And I'd start a plan. I was like, I'll see you in 3 months, right? But I needed an opportunity to give people 60 to 90 minutes of my time and then say, we're going to touch base every week to see what works, what doesn't work, whether that's dietary changes, neuromodulation, breathing techniques, mast cell stabilizing techniques, things that help with their POTS. There's no FDA-approved medications for any of these things. So we're making it up, which is
including
a very scary
Sjogren.
place. Including Sjogren. So yes, so that's a long-winded way to say that I felt that I didn't have adequate time to give the patients what they needed to tell their story, and not enough time to understand their response to therapy to tailor it in a personalized manner.
I know kind of in some of our conversations, Dr. Brittany, we've talked about that role of like dysautonomia in Sjogren's and how sometimes it's just really hard to diagnose. It's not fully well understood. I'm curious how that kind of has shown up over time too, because I should plug, Dr. Brittany has also done another amazing talk on the autonomic system and testing, which you have to check out if you haven't already.
So I started incorporating autonomic nervous system testing. We call it ANS testing for short. In my practice about a year ago, I want to say, as another tool to really help our patients and ourselves understand what we were treating. Somebody comes in and you have a list of symptoms. Oftentimes we'll call this a review of symptoms or check boxes on a piece of paper that you'll check, do I have these features? And in complex diseases like autoimmune conditions, that list gets to be really long and cumbersome because you have all these symptoms, and that may not translate to a lab test. We can run labs and tell you your labs look normal, but you have this checklist of symptoms that you feel, that your body feels. And so we started using this testing to help us identify and put language to those feelings or those symptoms that patients are reporting and say, yes, we can pick up on nervous system activity or lack of nervous system activity in certain body parts and movements like sweating, heart rate response, deep breathing, and actually identify if there's a disconnect or if it's upregulated or downregulated, so that you as the patient can not only feel validated, like I'm not making this up, I don't feel good. And then we validate that compared to either positive or negative laboratory tests, but also to help match symptoms of what types of targeted therapy we can discuss. So as we've all alluded to and Dr. Zach was mentioning, a lot of times when we don't have an FDA-approved treatment plan, we have to pick and choose different things that we know work in different kinds of conditions. So a lot of Sjogren's, right now there's clinical trials, and really soon we hope to have actual FDA-approved treatment options. But right now we pick from lupus medications and lupus treatments. We pick from rheumatoid arthritis medications and treatments, and we pick from nervous system treatment options. And so when we put all of these symptoms together and say, this medication can make this actually worse, so we don't want to use that. This medication actually can help maybe improve this type of symptom, so we might actually want to use this. When it seems like voodoo, sometimes these subtle little tests can actually reaffirm why we're choosing what we're choosing when we don't have that algorithmic approach. So that's where I've really found it useful, because we can actually show you who does the test, we're validating that you get dizzy when you get up too fast, or we're validating that your sweat response in your extremities is lacking. And so you don't have that communication to regulate body temperature very well or very effectively. And so that's, I primarily work in Arizona, so that's a big thing that we notice, right? If you can't sweat and you live in the middle of the desert, we have to help you accommodate for fluid maintenance and electrolytes and talk to you about all those things that you have to navigate. That's not intuitive, right? We think we're doing the best for our body, but do we really know? Well, sometimes it just takes somebody else offering a suggestion, maybe add a little bit of salt to your water or electrolytes, and that might perk you up a little bit in the afternoon, things like that. And I really like using it to help also identify more inflammation as well. So we use inflammation as a big I and little I, like trauma, right? There's big T trauma, little t trauma. I, in my practice, say there's big I inflammation, like you're having a gout attack and your whole hand is swollen. Or there's little I inflammation where you just know there's parts of your body that aren't functioning the way somebody else's body might be functioning. So we use this tool also to pick up subtle little I inflammation that oftentimes gets brushed off as, oh, you just have anxiety, or you just need to be on an antidepressant. Whereas we can actually test, this is legitimately your body's response to when your heart rate picks up. So
yeah. That reminds me, some of the first things I remember encountering when I started following your work, Dr. Bonnie, was really your holistic approach and using a term that was new to me, which was systems biology, kind of this, this idea that really honors the patient in a more holistic framework. So I guess as we think about needing more time, wanting the ability to have some better and more helpful diagnostics, I'd love to hear a little bit about that vision of kind of the shift in how we're seeing the person.
It's more than a vision. As an autoimmune patient advocate and an autoimmune patient myself, I have now interviewed more than 500 patients. And the general consensus among these patients from conventional medicine is that they are treated by body part. If you have a GI disease, you see a GI doc, and if you have joint pain, you see a rheumatologist. But the rest of the symptom clusters are never addressed, as we just discussed, and patients are extremely frustrated. A lot of patients have multiple autoimmune diseases, as we know. It's not just Sjogren's by itself, or it's not just Crohn's or ulcerative colitis. Probability of having a second autoimmune disease once you have one is much higher. I have 3 now. I'm not bragging, but they came in sequence and got layered up. And most autoimmune patients, not only are they frustrated that their symptom clusters aren't being addressed, their chronic pain isn't being addressed, and neither is the connection between the mind, body, and spirit. Many of them have been, sent to psychiatrists and psychologists and put on antidepressants. The patients we saw at Remission, where we did have a chronic pain psychologist, in addition to a nutritionist and other parts of our team, actually cried that they were so happy to have a multidisciplinary team put together for them. It originally came from my own experience as a patient a decade ago, where I had to put together my own team. I had to be the CEO of my own health. I had to hire and fire all the people that wanted to treat me by body part, because I had more than one body part that was affected, especially since my first diagnosis was fibromyalgia, where pain travels all around your body, varied on the day. So patients definitely want the kind of care that you guys are delivering. They want to be treated as a whole person, as a being. They want their mind, body, and spirit all together. And in the 500 interviews, believe it or not, there were many patients with PTSD or some kind of little t or big T, depending upon you, from the gaslighting in conventional medicine. Totally ignored, could not get seen. And I myself have experienced it, and I'm an experienced, sophisticated patient.
I can second that. I mean, I distinctly recall a conversation with someone I considered a peer, and I have the privilege of being able to know that she is a good human. And I think that her intention with her words that she chose was not to cause pain or hurt, but that was the impact of saying, like, I don't think it's anything, but I guess we can draw the labs, right? Like that, when you are scared and you know something is wrong, that impact really is profound. As we think about what that new model or better care actually looks like, I'd love to discuss a bit more about some of the practicalities of it, right? One of the things that you were mentioning early on, Dr. Zach and Dr. Bonnie, is this crucial role of the interdisciplinary team. And so maybe we could even throw out, like, who are some of those? We already mentioned some, but who are the folks that were a part of your team, Dr. Bonnie at Remission, and then maybe Dr. Zach can talk about the team he's building too.
We thought about it long and hard as a venture-funded virtual-first telemedicine startup in rheumatology, because we needed to think about the payment options as well as the fee structure. But what we opted to do, for better or for worse, is give the patient the highest type of care team that we could create. So this specific care team had an integrative rheumatologist. It also had a lifestyle medicine physician who spearheaded using lifestyle medicine as the first lever of defense instead of biologics. So in other words, part of the value proposition was, if you could treat people in an integrated care team, if you could use lifestyle medicine as a foundational pillar, could you prevent the use and or reduce the use of biologics? That is yet to be determined. The rest of the care team included a nutritionist that was specifically trained in autoimmune disease. And the psychologist part was very interesting, because we debated back and forth what kind of psychologist and or coach we should have to guide the patient through the journey. And what we opted to do first is we had a chronic pain psychologist for the psychology part, and we trained our medical assistants to be coaches and handholders, as I described them, during the patient journey. The patients thought the program was outstanding, and we did get very high clinical results and outcomes, and we saved money, relatively speaking. There are other models that we also had, of course, a nurse practitioner rheumatologist. And we were about to scale up and have more nurse practitioner rheumatologists. The idea there is to delegate down and let people practice at the highest level of their license. There's many models out there that are different, that have coaches and lower trained people. We did not try that particular model at Remission.
Dr. Zach, you had mentioned that you have dietitians. Who else do you have on your team?
I can't follow that, by the way. That was amazing. Like, look at this dream team that
I know.
Oh my goodness.
It was a dream team.
Yeah, that sounds amazing.
But it was an expensive dream team, actually.
Yeah.
So in venture speak, the unit economics at that moment in time were not, they didn't align with the vision of the next phase of growth.
Yeah, and that's always tricky, right? And then how do you set the payment models up? And challenging, especially from an Excel spreadsheet, numbers perspective.
But regardless of who you choose, the patients want a one-stop shop, in my opinion.
Yeah, and also for providers to communicate with each other.
Oh my gosh, yes.
So when I had my whole clinic today is dysautonomia, POTS, mast cell activation syndrome, and EDS. And you have some IBS and cyclic vomiting sprinkled in there, but I'm always calling their physical therapist, their pelvic floor physical therapist. I'm calling their OBGYN to make sure, hey, how can we get the hormones optimized? Talking to any dietitian, unless it's my own dietitian, just so we can all be rowing in the same direction. So there's not these disparate people, but ideally you'd come to, it's a one-stop shop, as Dr. Bonnie explained. My model is based on, I'm still building this plane in the sky. We're still pretty in the early stages of this. I'm a doctor, right? I got trained on medicine and pathophysiology, right? I'm pretty darn limited to what I can offer. You're kind of a fool to think that food doesn't impact in how we feel our gut and how we grow and how you build up your core muscles, and someone with EDS who otherwise lacks that core strength. So you need a dietitian, right? We have an exercise physiologist that helps us make exercise plans for those with dysautonomia who are really working to increase their blood volumes, increase their core strength, making derivations on what's called these protocols that exist out there for people with dysautonomia to exercise. I would love to hire a pelvic floor physical therapist. That's on my to-do list at the top of this whiteboard, right? Pack my kids' lunch tomorrow is hire a pelvic floor physical therapist because they're so incredibly important. And so that's and then I also partner very closely with the GI psychology group called GI Psychology. They're a telehealth-based group out of Virginia. I just think they're wonderful. Somebody give a plug. They're a group of GI psychologists that do cognitive behavioral therapy, hypnosis, all the things that kind of really reshape your relationship with your gut that's been perturbed for years and years, whether that's due to an eating disorder or pain or a defecatory disorder. And so it's important to identify who are the key players that really help someone succeed. And yeah, that's my ideal vision.
How would the pelvic floor PT interact with the electrophysiologist?
Like a neurogastroenterologist?
I don't know. The reason I ask is I am just beginning to learn about pelvic floor PT, despite the fact that I've had fibromyalgia for 3 decades. And I had to learn this on my own. So it's a kind of a patient question.
Yeah, if you come to a GI doctor and you say you're constipated or have infrequent bowel movements, there's a lot of reasons that can happen. But one of the most common and under-recognized reason is pelvic floor dysfunction that disproportionately affects women. I've heard a lecture by a pelvic floor physical therapist that if you've given birth to a child, you should see a pelvic floor physical therapist. And I find that this collection of women or patients or whatever you want to call them, just are comfortable with being uncomfortable, right? So what comes with pelvic floor dysfunction? It's not only the constipation, but it's the bloating, it's the pain with sex, the urinary incontinence, all these things that won't necessarily be brought up in a visit, but you start asking about them. You're like, oh my goodness, yes, I dribble all the time or I have a little incontinence here and there, but it wasn't enough, like it wasn't a big T to bring up in clinic necessarily. And then in those with hypermobility, Ehlers-Danlos, they lack connective tissue. And so they make up for it with hypertonicity in their muscles. So they have a lot of very tight pelvic floor muscles, which can in turn lead to a lot of symptoms. I'm sure a pelvic floor physical therapist out there listening would be like, he butchered that. Listen to my podcast. I'm giving the Cliff Notes version of it, but they're an incredibly vital piece of this team. and can give instructions that I wouldn't even know how to begin to even, I don't have a women's pelvic floor either. So it's completely foreign to me. And so having that input is also really important because I don't know, it doesn't make any sense to me.
Yeah. Dr. Brittany, how is your team set up? And are there any places where you're like, oh gosh, I'd love to have that person on my team too?
So all these things I think are amazing because as you're building a practice, it's very much, I would love to have this. I would love to do this. So my practice is a little more, I want to say, on the traditional side where we focus on rheumatology, but we're growing and evolving. So we are really working to build a network within our communities of people who speak the same language. And I think all of us have really expressed that language is so important, right? Like I can call, somebody and say, hey, I have this patient I'd love to send to you, but that patient might not have the experience you're wanting them to have with that practitioner. And so that referral then is not as credible as you would have liked it to be. So really building those partnerships with people who are very interested in these same sorts of complex conditions. So I've built a network of a team that I refer to in cardiology who does a lot of the POTS treatment. And then we have integrative practitioners who are doing a lot of our Ehlers-Danlos and hypermobility, the extra work that goes into those patients as well. And so we're really focusing on our community-based network because I think that helps empower patients to not only understand if you have an experience that you weren't satisfied with, here are the tools to be able to find someone who has some knowledge or experience in this type of condition. So really working to empower them of, if I'm going to Google or use ChatGPT, which now is actually very helpful for referrals, by the way,
Yeah.
to help them with the language of when you call to make an appointment, I would like to see the person in the practice who does this. And not so much assign them a name and say, I want you to see Dr. So-and-so, but I want you to see the person in the group who focuses on these things. And that can be really daunting. And that's one of the things that I think we talked about our experience in academic medicine. You're pushed to a certain path, right? You refer to the person down the hall to you because that's the specialty that you're looking for. But that person might not necessarily have an interest or accept really and go into those conditions that you are focusing on. Although I would love to have all of these types of people within my clinic, it's definitely a bucket list type of vision, right? Like how can we create these centers of health for these complex conditions? But I think in certain parts of the US, particularly what we call like specialty deserts or medical deserts, we have to learn how to identify telehealth practices who do these types of things. And we have to identify, who within the network that speaks these same languages. And so I use a lot of the Dysautonomia project resources. That's a tool I give my patients and refer to. You all are giving me really awesome ideas of how to connect patients even within your own spaces. And so it's really things like this where we get to meet people and talk about the things that we're passionate about that gives us an idea of, okay, I'm going to send you to somebody who focuses a lot on these things and who understands what I'm trying to refer you to. So my method right now.
Breaking down the silos that have built up around us in so many ways, like throughout our training, right? Like even I think about from an immunologist standpoint. So I did my training as an internist and pediatrician, and then focused on allergy and immunology for a couple of years. What we're realizing is there's so much crosstalk between the immune system and the nervous system, but I have been siloed away from the neurology experts since medical school because neurology was its own specialty, its own residency.
And you didn't interact. You hardly ever interacted except for the ER.
Separate service, we rarely shared patients. Like I remember I had a neurology intern once that was under me when I was a resident, but they were an intern, so they hadn't learned anything yet, right? So, I think that's what's been really humbling for me as I've continued to learn and lean into Sjogren's and mast cell and these things that really overlap the immune neurology spectrum. Because for the longest time in my mind, the only thing that did that was like MS, and this is not the case. So it's nice to have these opportunities to chat. I've been looking forward to this so much. I think, what you were talking about, Dr. Brittany, was this idea of really becoming the CEO in your health journey, whether it is, kind of through, separate entities or kind of in that one-stop shop. Regardless of that, I'd love to hear from each of you some of maybe the green flags and the red flags of things to watch out for or to ask so that people can really feel empowered to build that team that they need.
I can start from a macro perspective. Payment and reimbursement is a very interesting question because doctors need to get paid and patients need to be able to afford to go. But how do you bridge that gap? It's a huge gap. So what we did at Remission is we started as a fee-for-service practice with the big picture goal to transition to value-based care. So value-based care is a concept in conventional medicine similar to Kaiser where you bundle payments of a team-based approach and you come up with one fee that you are reimbursed, whether it's per month or per year. It hasn't really caught on as much as people think in conventional medicine for a wide variety of what I will just call turf battles among specialists and all sorts of other people. So if you're talking about conventional reimbursement, what we found at Remission, of course, the team that we built, we could not support if you was just a fee-for-service practice because the reimbursement is such that you got some level of reimbursement for rheumatology, nothing extra for the integrative rheumatology or the 1 hour first visit. You got some level of reimbursement by some insurances for the nutritionist at pennies on the dollar and not very often. The chronic pain psychologist was reimbursed. Yes and no. The lifestyle medicine person was reimbursable, which is why we went with lifestyle medicine. But in essence, it was really a loss leader. We did not make money at all. In fact, we lost money, which is why we were raising money. So that's this quagmire of the types of reimbursement, whether it's a fee-for-service and how you're going to rationalize that in a venture-funded startup with a concept of being in the mode of transition to value-based care. We also had a cash pay option for people that didn't have the insurance. It was very popular. So direct primary care or direct reimbursement or fee structures that patients can afford is another viable option. And there's a lot of different models all over the map. And I know we all want to try to treat the people that can't be treated and don't have a lot of money, but we haven't quite figured out how that's going to work and stay in business and be reimbursed.
Yeah, it's well said. Just to provide context, a month ago, I was seeing 16 patients a day. And a lot of times it's how quick can you get someone on the hook for an endoscopy? That's the price of admission to seeing a GI doctor. And do you know why? Because it pays a lot of money, right? You get paid a lot of money. There's a hospital administrator that said, why can't you guys just do EGDs all day? Because you can do like 70 of them because it takes 5 minutes and the reimbursement rate's really high. Yeah. And so that's how the industry is geared. And so when I was doing the math in terms of, to be candid, I run a cash-based practice. We do not take insurance and it breaks my heart. I have a meeting on Friday to try to figure out how to do this. I've never built a business. I'm an MD, I'm a clinician, so I have no idea how any of this stuff is. I'm learning as I go. But in doing the math, I said, if I'm going to give 80 minutes a day to people and say I'm going to dedicate each week to responding, to giving an hour and a half a day to responding to messages to continue to tweak the plan, insurance won't reimburse for that, for those ongoing communications. It won't. And there's no way to bill for that. I'm having a conversation. There's a patient of mine who sends me 2 pages every day and I send him a page back, right? Because we're working through trauma and why medication is so hard and what's going on in his nervous system. I can't bill for any of that. And I also have a bunch of kids. I have to pay a mortgage. And so there's a reality here that's tough to swallow. And I get messages every day on my Instagram being like, you're a crook for not taking insurance. And I agree with you. And so I don't like, that's just,
I actually don't agree that you're a crook for not taking insurance because the insurance reimbursement is relatively low relative to the time you're going to spend. As 80 minutes, we spent 60 minutes. So
I said that tongue in cheek. A lot of people spend a lot of money monthly on their insurance plans can't get the care that they need because there is not a subspecialist near them, or it doesn't even have to be a subspecialist, people that recognize what POTS are, right? Cardiologists didn't go through cardiology training to treat POTS. That's not why they got into this. So there's a huge no man's land for people with these conditions. And similarly in Sjogren's, I just thought it was dry eyes until I listened to the Dr. Bluestein podcast with you, Kara. And so there's so much misinformation about these things. And the people that have these really tough to manage conditions who financially can't afford cash pay models, it's really tough. I'm trying to be creative and think of ways to make this affordable. Payment plans, like you pay for one visit and we just talk in perpetuity on the MyChart or my patient portal. We try to make it work, but it's an imperfect system.
And our system doesn't, unfortunately, recognize intellectual specialties the way it recognizes procedural specialties, right? You talk about EGDs, and likewise, I'm married to a cardiologist and electrophysiologist. And intellectually, what we do all day, every day is very hard, making these decisions, coming up with these tweaks on each individual patient and formulating all these plans, right? There is no roadmap for any of this. And if there is, it's you start here and your goal is here, right? But how you get there is different for literally every person. And our healthcare system just is not built to support that kind of medical practice. And it shows, right? We devalue preventative care in favor of reacting to disastrous outcomes, heart attacks, strokes, all the bad things that happen, right? In rheumatology, I spend so much time talking to my lupus patients about organ damage to their kidneys and trying to prevent them from being on dialysis, when if we went back to the very beginning and caught things much sooner, right, how would that outcome be different? And for Sjogren's especially, the interconnectedness of all of these different specialties and all these different symptoms, our medical system doesn't value that right now. And so how do we create that value in a system that doesn't see that? And that's, we talk about healthcare economics, right? What does it mean to spend all this money on outcomes? But how do we bring it back to the very beginning and think about the trauma? Are we trauma informed? No, we have to teach ourselves how to be trauma informed. We don't go through medical school learning anything about how trauma affects the body. We're lucky to learn about the gut microbiome and how that affects the body. But everything comes from those key things that happen to us as individuals. And so it's frustrating, but yet, I think we're trying to innovate ways to change that. But what I wish that patients or just people who are observing this understood is that we're at the mercy of an economic system that controls us in a way that is not structured to have a livelihood in the way that the group of us are talking about practicing medicine. And as frustrating as it is,
from a patient's and a big picture public health perspective and how we all want to help those who can't afford the cash pay model, here's one of the venture-funded sort of big picture ideas. To use digital health, to use digital tools, to use AI, to use all these evolving systems to identify patients earlier from a systems biology perspective and actually get into prevention. Now, how does that actually happen in the real world? Practices like you guys have collect data on patients and actually show they get better.
Wow.
With this high-touch systems group approach. Because once we show that, then that's cost savings. You've gotten the patient better without surgery, without ER visits, without high-cost biologics, and or some combination of all of the above.
Dr. Bonnie, she gave me that advice a couple of days ago, and I handed out 9 questionnaires today, and everybody was stoked to fill them out. Yeah,
Thank you.
But I also say that the questionnaires for mast cell are invalidated. So you can in this space it's so tough to collect data when POTS has validated questionnaires, but there's just the amount of issues that come up when trying to better understand these patients are infinite. And going back to
pioneers have to start somewhere. How are we going to develop predictive markers for autoimmune disease earlier without something?
Yeah, no, and topic for another day, but within mast cell, there are these 2 camps, right? And goodness, how much further would we be if we could get consensus 1 and consensus 2 people at the same table to have a civil conversation?
Yeah.
Silos.
Talk about
And I think we're really at a division too, where there's people who are wanting to learn and doing things beyond your normal day job to learn this language and learn techniques and learn about all these different tools. And then there are people who are not doing those things. And so the vast majority of clinicians right now are still doing things the way they've always done them and not necessarily taking the steps to develop innovative approaches. And so we're at this divide of we've got to get on the bus all together and really help each other learn and navigate how our healthcare system is changing. And I was listening to a Malcolm Gladwell audiobook, and he was talking about the development of essentially like how streamlining chest pain patients became a thing. And the observation part of the hospital and screening patients, are they really having a heart attack or are they coming in with chest pain? And in the autoimmune world, we're at that forefront of like, how do we predict who's going to be managed without much intervention? And maybe a lot of these non-medical approaches versus patients who their trajectory is happening very fast and needs treatment to slow down and halt the rapid progression. And how do we identify these people? And I think we're there, it's happening. And I think we're building ways to figure this out.
Autoimmune is a large and growing market, sadly, growing fastest in young adult women. So yes, we need to do that.
I would like to go back to marrying your point and the limited time that we have in clinic. Going back to our medical school days, I spent loads of time learning about pretest probability of all these tests. Here's the rub. For these conditions, the tests aren't that great, right? The likelihood ratios stink, which means that if I think something is happening and I order a test, whether it's positive or negative, it doesn't really affect how I feel afterwards because they're poorly understood. And as such, we don't have good testing for it. Why it's poorly understood and why these are disproportionately affect women, that's a different conversation for a different day that we don't understand women's bodies. But when we sit in clinic or you go to the ED, it's how quickly can I order a test to figure out what's going on? Well, what happens if we don't have a test for what's going on? The biggest test that I have is talking to somebody and seeing what has worked, what hasn't worked, what's affected your symptoms. When's the last time you felt good, right? What's made it, like that's like creating a narrative is my biggest, the best test that I could run. Guess what that reimburses? Nothing. And so we need to go back, the medical students, we just need to put so much more attention into understanding the patient narrative. Like when I was a resident and a fellow and residents were writing notes, I was like, you get one problem. Don't write like subclinical hypothyroidism or whatever. Everything is due to one thing. Create the narrative, understand the story, right? How did they get here? It's all one thing. Find the common denominator and work your way back, reverse engineer what's going on. Because the testing is fine. Of course you're gonna run tests, but yeah, when you're dealing with this patient population, the testing just doesn't move the needle. So you just gotta listen to people. And unfortunately, the model of medicine doesn't prioritize listening.
And I think what I've said before is that one of the first lessons we learn as students is listen to the patient, treat the patient, not the test results. But one of the first things we forget when you get on that treadmill of seeing patient after patient is that you stop trusting or maybe you don't get a chance to even trust your clinical judgment anymore. And, I really think that's playing a big role in what we've seen with Sjogren's disease, because one, most folks don't realize or don't let it sink in that 30 to 40% of people have normal blood work. And so if the lab is normal, high five, it must be normal, or fibromyalgia or something else that's kind of like, used as the brush off. Just part of like my last 6 years is like, what is the reluctance and to what level of certainty do we need to have to say, well, it looks like a duck, it quacks like a duck, it has feathers, a beak, and, the little feet, right? With mast cell, for instance. Nope, got to have a positive tryptase. Can't Sjogren's, we don't have a positive SSA.
But then we also learned about the differential diagnosis. So if it's not, tell me what's going on. What's the statistical likelihood that this 26-year-old has migraines, IBS, allergies to everything with negative IgE testing, and endometriosis? What's the statistical likelihood that's going to happen? So if you can create a counter that this is not mast cell despite a negative tryptase, yada, yada. But that pertains to everything, right? We've lost the ability to talk to people. And I think we're under a time crunch as well. And what do insurance companies reimburse for? It's the fancy schmancy testing, right? So every POTS patient that I have, I can talk to them. I was like, I know this is POTS, right? Get an EKG. That's all you need. Make sure it's not like WPW or SVT or something like that. But do you need a Holter? Do you need an echo? Like you have hypermobility, an echo is fine. But everybody gets all these tests. And one of my best friends is a cardiologist. Like he knows POTS when it steps through his door. But you know exactly the test you're going to order, and you do it because it's done, but not necessarily because it's going to look for what's going on. And you do it because that's what we were taught to do. So in GI, you have abdominal pain, you're going to get an endoscopy. What's the statistical likelihood we're going to find the answer in the endoscopy? It's less than 40%. The upper endoscopy is one of the worst tests out there, unless you have dysphagia or bleeding. But for pain, for what it's commonly used for, get an endoscopy. Oh, maybe it's ace pylori. Test it with a stool test or a breath test. Like you can rationalize getting these invasive tests to yourself because honestly, that's what you get reimbursed for. And the guys who make the most money, they do all the tests, right? And so you get caught in this vicious cycle of, I don't have enough time to talk to my patients. Let's just get some testing. Okay. Oh, this testing, actually, that makes my paycheck look a little bit. You can convince yourself that this is the way to go. And when the testing is normal, it's, I'm just not sure what it is. I'm sorry. Eat more fiber, try to meditate, because people stop being curious. Like young doctors asking what to do, like never stop being curious. Like, why does that person have 40 allergies? It's not because they're a pain in the butt. It's not that they want to be allergic to everything. Like think about it. And if you just limit yourself to, the endoscopy is normal, it's a stupid test. It's not that good a test, right? Start thinking. And that's where people stop doing because, I don't know, we have kids, right? You're out of training. You're done busting your butt, right? You earned your keep. I get that. There's so many different kind of talking points here as to why the system.
And I'm going to add one little asterisk too from a conversation I had with a colleague this morning. Family history of hypertrophic cardiomyopathy. So her son needed an echo at the local children's hospital for screening. She got a $2,000 facility fee for all of that testing. So not only are you paying for the doctor's visit, the echo, the EKG, everything, but at many of these centers, you're also getting kudos from whoever is writing your paycheck because they also are able to charge these additional fees just for being wherever you are.
Who owns the facility?
The healthcare system or center, or
Doctors do too, right? So it's like this. You create this world which, like, you order a test and you get these huge reimbursements, and it's if your patients love you, right? You have good outcomes. You get a pat in the back.
Yep,
that's it.
As we're getting close to summing this all up, I want to come out from this conversation with a little bit of forward thinking, maybe some calls to action. Like, where do we see the future in 5 to 10 years? I'm guessing, Dr. Bonnie, you have...
Yes. First of all, putting on my patient advocacy hat, I would encourage all the patients listening to really take this, be the CEO of your own health seriously, and put together your own care team, whether it's with one of us or whether it's in the conventional medical world. Fire the doctors that aren't listening, that are gaslighting you, and that aren't giving you what you want. And find the practitioners that you need. And I'll just give a small example in the exercise world. Fibromyalgia, 3 decades, nobody knew really what to do. I had to put together my own exercise team. I've done Pilates, gyrotonic, Feldenkrais, things I never heard of. So I encourage all of you to be curious, be open, and put together a team that works for you and become the CEO of your own health. Putting on my investor venture capital world hat, I am determined to leave a legacy of improved care for autoimmune patients for the next generation, which includes my 10 grandchildren. And doing that, since remission has closed, I am going to try, and this is a huge ask, to raise a specific investor fund for autoimmune disease. And it will put the patient at the center and look across the spectrum to use data, digital analytics, new tools for better diagnostics, more prevention, new medical devices, and new ways to deliver care. So I would ask if anyone knows affected families who are well off and want to invest in leaving a legacy of improved care for autoimmune patients, you can find me.
Awesome. I would love to hear if everyone could give us the single most important piece of advice you would have for a patient who just feels lost right now. And that's maybe why they're here.
Oh man, that's a good one. You got to find your support network somewhere, and that's easier said than done. You could say whatever you want about social media. It has created amazing support groups for people. I do this Instagram page, and just going through the comments alone, you've seen people being like, whoa, I have that. Now this is making sense of well, all my testing is negative too, and you got better with that. So you see other people navigating these like in similar shoes, similar symptoms. I see that they've got a provider that listens to them, and there is a route to getting better. Obviously, everybody's path isn't the same, but finding your support group, and it starts with reaching out on social media. There's great Facebook groups out there, and then patients talk about other physicians that they see. So I think word of mouth really helps. And if you're listening to this talk by design, it's part and parcel. You probably have something really complex going on that's invisible and chronic, yada. And by design, you've probably had all the tests done. So go out there, talk to people, go on social media, support groups, find your provider that listens to you, will take it seriously. And that's where it's going.
Take us home, Walter, Brittany.
I second that. All of these things are wonderful advice. I think mine is really put in the time to develop the language so that you can communicate to your healthcare team what it is exactly you're trying to explain. Because a lot of times when we're in visits with patients, there's a lot of, I don't know, you're the doctor, you tell me what you think. We aren't in your body. And so when you can have a word or a phrase that connects something that then triggers us to ask other questions. For me, for example, as a rheumatologist, it's pain and stiffness. Are you in pain like you just got your foot run over by a car, or are you stiff that you can't open your hands or your joints? And so the language that we use together is so important. And if you're looking for that healthcare team that tries to pull words out of you, it's going to be a little bit challenging. So if you come prepared, I feel like this activity hurts me, or I feel like this bodily function doesn't go right for me, where you can give like a story to what it is you're trying to communicate, then there'll be something eventually that clicks and says, oh, let's explore XYZ, versus the very kind of passive approach of just, I don't feel well, I'm in pain. So, when you check those boxes of the way that your symptoms make you feel, having the story behind that is really helpful for us then to ask questions and tease those things out. I know it's a lot of effort, but watching social media, talking, we all kind of said talk, right? Practice having a mock sort of encounter with maybe a family member who's willing to ask questions or you're willing to share details with, so that it becomes second nature, that you're not like nervous in the office visit of, I'm so embarrassed to say these things. Spill it all, because oftentimes the more information, the more symptoms, the more problematic things we identify, we can put those pieces together quicker, right? And come to a treatment plan that's not so ambiguous a lot of times. So I think my best piece of advice, again, with what everybody said, is work on developing your language for communicating what you're actually trying to say.
I find that I agree with everything that you said, and coming as prepared as possible. I find that patients who have been quote unquote gaslit or have seen multiple doctors are so apologetic about their symptom because they don't want to put too much on, like their review systems are, and they're like, they try to be so careful with their language to not offend the doctor because they've felt defensive the whole time. Like, go to the ED, they have pain, CT scan's normal. I don't know, like it's something that you ate, and that's not something that I eat. I eat this all the time. And so I think what you said was perfectly right, like trying to empower the patient to feel like what you're feeling is okay. And it's okay to tell us everything. Even if you have that initial wallop, like maybe they didn't want to hear about this or that. We want to hear about everything. But to your point, like the more organized, the better. Focus on the things that really bother you, because if you can start there, the conversation can flow naturally.
And I would build on that with one final thought for the patients listening. The pain in your head is connected to the pain in your foot. And don't let the different doctors think that it isn't. It's also connected to the pain in your back or the pain in your stomach or the pain anywhere in your body. They are all connected. They all work together. And just because specialists are still divided up doesn't mean that they don't all exist.
And even back to whenever in history we decided that dentistry was separate in this whole different ball game compared to medical doctor kind of stuff, we're all one. We're one, one being, and it's all interrelated. Thank you to each and every one of you for making time in your schedule so we could join from all parts and all different time zones. I think we don't have the central time zone today. We should have had someone there, but we have Pacific, I think, at Brittany Mountain right now. And then Zach and I Eastern, getting our schedules all coordinated. What a really great conversation. And I'm really excited to see the ongoing conversation in the comments throughout. This has been really exciting. And let's see what the patient conversation and our conversation evolves. Maybe we'll have some new, amazing, creative ideas with all this curiosity that we have for how things could be better.
Agreed.
So much.
Thanks, Kara.
Thank you.